Welcome, everyone, to our session today, Advancing Primary Care, Evidence Needs to Deliver High-Quality, Equitable Care. And I'm Arlene Bierman. I direct the Center for Evidence and Practice Improvement at AHRQ. And I'm thrilled we have two distinguished guests today, Dr. Jennifer DeVoe. She's a John and Sherry Saltz Professor and Chair of the Department of Family Medicine at Oregon Health and Science University, and was actually a member of the recent National Academies panel on implementing high-quality primary care. And Mark Smith, who's very well known, is a clinical professor of medicine at the University of California in San Francisco. He was the founding president and former CEO of the California Healthcare Foundation, among numerous other activities. So welcome. Thank you. AHRQ is the lead federal agency for primary care research and strongly believes that revitalizing the nation's primary care system is foundational to achieving AHRQ's mission of improving the quality, safety, accessibility, equity, and affordability of healthcare for all Americans. What are we talking about when we talk about primary care? Jen is going to go into this in more detail, but I really wanted to highlight a couple of points from the new definition of primary care in the recent NASEM report, which says that high quality primary care is the provision of whole person, integrated, accessible, and equitable care by interprofessional teams that are accountable for addressing the majority of an individual's health and wellness needs across settings and through sustained relationships with patients, families, and communities. And I think there's a couple of things to highlight here. The need for equitable healthcare, the need for care that's integrated, the need to figure out how to organize, pay for, and use interprofessional teams, and the whole concept of sustained relationships, not only with patients, but also their families and their communities. So AHRQ has a long history of supporting primary care research, and we have a lot to build on. We know that primary care is associated with better population health outcomes and increased volume. And we know a lot about the different elements of primary care. We funded work on the patient-centered medical homes, invested in primary care practice-based research networks, developed tools for practice facilitation and understanding its role, studies on the transformation of primary care, optimizing care for people living with multiple chronic conditions, integrating behavioral health in primary care, and the primary care workforce. So we're not starting from scratch. And I think there's growing momentum. We know that despite all of the interest and work in primary care is still threatened and is still not central to our health system. And there's been a number of reports in the last year that have been issued or are in process that I think can generate some momentum in really advancing both primary care and the research to support this transformation. So in 2018, Congress authorized an independent assessment of federally funded health services research and primary care researchers. And this study, acknowledge that they are distinct, even though there's overlap, and identified a really large research agenda needed to fill the gaps. And in summary, there were basically two overarching themes identified: research to understand how to best implement and make work the core functions of primary care to holistically address patient needs, and then primary care transformation and its role within the wider healthcare system. I'm not going to talk about the NASEM report because Jen is going to focus on this, but this report, basically starts from that. We know that primary care is needed. We know it's missing in our health system, and really provides a roadmap and some suggestions for how to actually move forward. Another report, AHRQ is working on a report that should be out this summer on the study of state-level actions to improve the delivery of primary care. So this was in response to a congressional mandate we're funding a study of state-level actions to improve the delivery of primary care. And the specific aims of the study are to promote an understanding of which state actions have helped improve primary care, what conditions and factors positively and negatively affect the results of state actions, and also, most importantly, to provide findings and lessons to inform federal initiatives to improve and expand primary care. And so the study will produce a final report and executive summary by August 2021. And the key findings we're hoping will be widely disseminated as well as delivered to Congress. In the fall, in December, we held a summit celebrating AHRQ's 30th anniversary of primary care research, and engaged a wide range of stakeholders to really outline what should the research agenda for primary care be going forward. And we're in the process of developing a research agenda based on that input, which we're hoping also to release later this year. We all know the impact that COVID has had on the health system, writ large, as well as on primary care. And I think it's really spotlighted, the shortcomings of primary care in our current health system, but also unleashed a lot of innovation and resilience. And from this, we could really develop a lot of evidence about how to move forward. We know the functions of the medical home have had some success in some places, but we also know that the medical home is not enough. And in the future, we need to really understand the role of primary care within the larger healthcare system, both in connection to other sectors of care, specialty care, acute and post-acute care, but also on the other side to public health and community organizations, et cetera. And, there's a growing recognition of the social determinants of health and the relationship of primary care to other sectors and the social needs of their patients. And clearly they cannot reinvent systems that already exist, but I'd like to give an example for if you have a practice with a lot of patients with diabetes who are food insecure, having those relationships to connect people to healthy food in the community and other resources can really help improve clinical outcomes. At AHRQ, we developed the Care and Learn model as a kind of a framework for informing some of our research agenda setting. And this is a functional model of the health system based on the learning health system model. And I'm not going to go into detail about this, but what I want to say is what we realize, there's a lot of work on patient-centered care and how to deliver, care that, improve relationships and patient experience. There's also a lot of work being done on data, evidence generation, predictive analytics, and they're two separate worlds. So what this model tried to do is to say to have successful care delivery, you need to integrate both the caring and the learning functions of the health system. And clearly to make the system successful, primary care is central to do that. And we can start thinking about primary care as a learning health system, and how can we make primary care practices and networks, as well as our research efforts, use the principles of continuous learning to actually implement and transform the system. AHRQ is tasked under the Affordable Care Act to disseminate and implement evidence in practice. And what we've realized is that we really need to integrate quality improvement and implementation science and learn while we're implementing. And so while we're learning a lot about how to actually transform primary care through this, I think it could be a model for primary care research in terms of, not to wait till we have the evidence, but to build the evidence as we're implementing change. And so far we have 4 evidence now initiatives that have been funded or are in the process of being funded, and they each focus on a different aspect of primary care. So Advancing Heart Health worked on building quality improvement capacity in small and medium-sized primary care practices. We developed, we provided resources from the communities, the tools for change in terms of anybody could now access what the practices learned. This included 1,500 small and medium-sized practices in 7 regions across the country. We're building on that by targeting the states with the highest burden of preventable cardiovascular disease, targeting blood pressure control and smoking cessation. And in this one, we're actually encouraging ways to link primary care and public health efforts in the state, so that the population health efforts, for example, at smoking cessation, can be linked with what practices are doing. We have an initiative on managing unhealthy alcohol use in primary care, which is developing models for integrating behavioral health in primary care. And our newest initiative managing urinary incontinence in primary care really wants to take a system level approach, and how can we do multi-level interventions that align resources in the community with primary care practice and with the health system, at the same time meeting people who, many of whom have multiple chronic conditions, and delivering care in a way that is patient-centered. And finally, we do have capacity. We've been building capacity over, the last few decades to actually do this research, and we can really focus on what resources are out there to accelerate the research and accelerate the evidence development to transform primary care. And for example, the practice-based research networks, there's currently 169 in the US that cover about 1/3 of the US population. So I'm going to stop there and turn it over to Jen, but I just want to say, and with a quote from Nelson Mandela, it always seems impossible until it's done. So I'm optimistic that we will be able to make movement in primary care.
Thanks so much, Arlene. As Arlene said, I'm Jen DeVoe. I'm the professor and chair in the Department of Family Medicine at Oregon Health and Science University. Thanks so much for allowing me to speak with you today, and look forward to the presentation and discussion. So these are a couple of pictures just to let you know that everything important that I've learned and that I'm going to share with you, I've learned from patients and families. The patient you'll see me pictured with here on your left is a patient who thanked me for saving her life. And it was a real, obviously, rewarding moment as a primary care physician, but also reminded me of how much work we do that's invisible and how we often don't get credit for saving lives, although there's data to show that primary care physicians are directly associated with improvements in population health and life expectancy. The patient on our right, a very special person, my father, just before his death, he reminded me as well of how important it is to have a long-term relationship with someone who knows you and can help you make very critical end-of-life decisions. So again, all of these are lessons that I've learned from patients and families. Primary care is a life-saving intervention. Primary care is the only part of the healthcare system that results in longer lives and more equity. Primary care is an essential, not optional ingredient to successful population health improvement strategy. It is possible to deliver old-fashioned, futuristic primary care. Primary care is weakening in the US when it is needed most, and we need to get primary care off life support. And as an academic, I have published on all these articles. So published articles on all these topics and incorporated the stories from the patients who have taught me these important lessons. And those are listed here as any good academic listing your publications and citations. The one at the top there, getting primary care, a life-saving intervention off life support. I do want to read a clip from it that's related to the current context we find ourselves in within the COVID pandemic. Last week, and this was shortly after March of 2020, it will be emblazoned in all of our memories forever, but shortly after we made a significant amount of transitions and transformations very quickly to respond to COVID. Last week, an insurance company executive shared with me that he was surprised to hear how hard primary care is working right now because he thought our practices were closed. Why would he think we were closed? As primary care teams flex to meet increased needs and work to create community-based management for the majority of COVID-19 infections, while also accelerating ongoing efforts to treat chronic disease, manage worsening mental illness, address social determinants of health, and creatively deliver preventive care safely, primary care's presence is even less visible, given that a smaller percentage of the care being provided right now is billable. So at a time when our teams are working harder than ever, they are getting paid less and have become even more invisible. Primary care teams are doing everything possible to stay open keep people safe, and to serve increasing demand with dwindling resources. When there is a mismatch between what society expects of a service and how we pay for the service, it can be taken for granted. It becomes an invisible service that everyone feels entitled to receive. What happens when demand for non-billable primary care services suddenly skyrockets and billable services plummet? Or when the paid portions get out of balance with what the community needs, such that primary care teams are in an ethical dilemma about where to provide the services that are paid or the services that are needed. These are sometimes mutually exclusive. The COVID-19 pandemic is a stress test in how we pay for primary care and what we expect of primary care in multiple ways. It is showing the gross mismatch between a fee-for-service payment system and what we need primary care to do for our society right now and in the future. We are failing this stress test as a nation. An integral part of our system, primary care, already on life support, is about to code. So thankfully for my sanity and for our country's future, we were in the midst of working on, in the midst of working on the first report solely dedicated to primary care at the National Academy since 1996. And well-timed for this presentation today, this report has just been released, is available at the National Academy's website. But this was an exciting opportunity within the context of COVID, knowing what we know so well about the strong evidence for primary care. This was the opportunity for a really amazing group of folks. Here's the committee members here, the diversity of background, opinions, experience represented here, and also contributing to this report to really provide an implementation roadmap or a blueprint for how to move forward. So one of the things that those of us who know primary care and know not only primary care, the spending on primary care, but the spending on primary care research, we know that while a large percentage of the visits and the majority of care provided in this country as far as visits happen in the outpatient setting, and a large percentage of those in primary care, the expenditures for the large part go towards inpatient care, where a very small percentage of patients are receiving their care. Arlene mentioned that we updated the definition of primary care. She mentioned it earlier, so I won't read it again here, but this is what we're talking about. I think one of the things that resonated with me when I recognized that primary care was invisible, but yet it was taken for granted. I don't know how many times I heard early in the pandemic, call your doctor, call your doctor, call your doctor. But when I started looking at statistics for the state of Oregon, 25% of people in Oregon don't have a primary care provider. They don't have someone that they can call when they have all these questions or they have concerns. Primary care is a common good. It has high societal value. Again, I don't think a lot of people would recognize it until it disappeared. But there was a doctor needed, there was a primary care clinician needed for everyone in this country this year, and a lot of folks didn't have that person to call. Primary care is a common good, and it requires public policy for oversight, and we need strong advocacy and organized leadership. So the committee put together an implementation plan. Again, it's over 400 pages long, the report, but there's some really very digestible sound bites, great graphics, lots of exciting opportunities to put things on a slide, as I've done here, to talk to different groups of folks and to really understand where we need to go. We have the system view targeting actions at 3 levels of the US healthcare accountability to understand who at the federal level and the state level is accountable, who's accountable for primary care, the robustness of primary care, the quality of primary care. So we have some ideas here about creating that unified body at the federal level, creating a scorecard to track the progress of where we're headed. And COVID-19, as well as other experiences in the past, have shown us that primary care is incredibly vital to our nation. 5 objectives, as I said, on these beautiful slides put together by the National Academies: payment, workforce, access, digital health, accountability. Sounds simple. We also have these 5 objectives that also sound very simple, but the good news for this group is there's a lot of research needs to be done in the future. These are all founded on very sound evidence, and then there's a lot of research to happen in the future to help us hone in on some of these objectives. So 1, pay for primary care teams to care for people, not doctors to deliver services. I think that was another lesson that I learned over and over again during COVID. As I said, we needed to be caring for people, not worrying about which services were billable and which services were not. 2, ensure access. High quality primary care is available to every individual and family in every community. 3, train the primary care teams where people live and work. 4, digital health, which was a new chapter and a new world as compared to the 1996 report. I know Mark's going to talk a lot about this, so I won't go into detail here, but we really do need to design new information technologies that serve primary care and that enable and facilitate primary care to happen at the highest level. And then accountability, ensuring that we have high quality primary care in the United States. So just briefly, I'll go into a couple of the actions. There were several actions within these 5 objectives. The ones related to payment really resonate with me, and I've been really writing and thinking a lot about these areas, including the patient story and article that I shared earlier. The first action is we need to evaluate and disseminate payment models based on their ability to promote the delivery of high quality care and not worry so much about short-term cost savings. I think we've gotten into a cycle where we want to see a huge return on investment with a small investment in primary care, and we want to see that within a couple of years. And we've forgotten that there is a quadruple aim, and there are other aspects of that that are super important related to population health, patient experience, equitable care, equitable access to care, as well as the wellness of our teams. The second one, payers using fee-for-service models for primary care need to shift to hybrid reimbursement models. The third action, CMS should increase the overall portion of health spending for primary care. And fourth, that states should facilitate multi-payer collaboratives. And here's another slide really looking at phasing out full fee-for-service towards a more hybrid model. And again, I think here, getting back to what Arlene was talking about, where we need to be learning while implementing, there is sound evidence that we need to change. We need to phase out full fee-for-service. There's sound evidence that we need to do something incredibly radical, or many things incredibly radical. But what? That's where researchers come in. That's where we need evidence to understand what radical intervention that we're implementing is better than another for a particular patient, family, or community. So a really exciting time that we need to move. We need to move in radical directions, and we need people walking right alongside the innovators to evaluate and understand what's working and what's not working and why. A couple of the other areas that I want to highlight, ensuring access. This is really talking about empanelment, talking about universal empanelment. Every person in this country should have a declared usual source of primary care, and that for people that aren't in particular payment or insurance plans, that there are health centers, hospitals, and primary care practices that can take care of those uninsured patients, and that we need to create new health centers, federally qualified health centers, rural health centers, school-based health centers, centers within the Indian Health Service and other places to address the shortages in some of our most underserved counties. The third one, training primary teams where people live and work. Again, this is really looking at continuing to diversify the workforce, having government agencies that are helping to ensure that we have adequate educational pipelines. Some of the programs listed here in Action 3.2 that have been shown to be successful, those programs need to be maintained, strengthened, and expanded. Designing information technology that serves patient, family, and interprofessional care teams. Again, I think Mark is going to highlight some of the details here, but we really do need to get to the next phase of digital health certification standards such that we can support what happens in primary care. And this is relationship-based, continuous, and person-centered care. There's a number of other areas where the Office for the National Coordinator and CMS can intervene in order to make our information technology more patient-friendly and work better to support primary care. And lastly, accountability. And this is accountability at the national level, the state level, the regional level, to ensure that primary care is being supported such that it's reaching every person in our nation. And this looks at what HHS can do in creating a Secretary's Council. There's also quite a lot of work and recommendations related to where we need to beef up areas for research, both within AHRQ and NIH. And here we are, an Office for Primary Care Research at NIH and funding dedicated for primary care at AHRQ. So I will turn it over to Mark. Thank you for listening. As I mentioned, there's a 450-page report that can be downloaded and lots of other exciting resources related to the evidence and the recommendations that this committee produced.
Good morning. It's a pleasure to be with you, and thank you, Jen. A confession. I am a recovering primary care romantic. I trained in the early and mid 80s and started my professional independent career in the late 80s, early 90s, during the romantic period of primary care, where we were supposed to take care of patients in the office. We were going to take care of them in the hospital. We were going to know what kinds of chemicals they were exposed to at work. We were going to take care of them at home when they were dying, if you were a family doc, when they were born. And obviously, some of these roles have changed in the intervening 30 years or so, particularly in the hospital. And it's worth pointing that out because I think from my standpoint, I'd like to talk about what I think the research tasks are for primary care in the 21st century, in a world in which the healthcare system and patients' expectations of service have changed dramatically since the foundations of primary care and our belief in it were laid down by Barbara Starfield and others many years ago. It's worth noting, as Arlene said, that the primary care research agenda of AHRQ is both about the content of primary care and what should be done right and well itself, and also the role that primary care plays in the larger healthcare system. So let me just point out again that our definition of primary care has to be a dynamic and not a static thing. And that over the years, many things that were thought of as being part and parcel and unmovable and immutable part of primary care have gone away, including, for the most part, in-hospital care. Much of care of people in their terminal phases is now given over to hospice specialists and others. And so it's worth thinking about the fact that many of the things that primary care physicians of my generation were taught to do are now done by so-called mid-level clinicians successfully with new technology and with algorithms. Other things that we were taught to do by diagnosis and by a careful going through an algorithm are now done by proceduralists much more quickly and much more accurately with, say, bedside ultrasound or endoscopy to diagnose ulcers. And many of the things that proceduralists and primary care docs alike have been doing are now done by computers and will increasingly be done by computers, whether that's recognizing an EKG or an anomaly on an X-ray or reading a nuclear medicine scan. And of course, lots of things that doctors and nurses and others used to do and are still doing for payment purposes can be done and should be done by patients. So it's worth considering the role of primary care, not as it has been historically, or even maybe 10 years ago, and I would argue maybe even 1 year ago, because of the things that COVID has taught us, but to think about the research agenda for primary care in a 21st century world. What are the tasks of tomorrow's primary care doctors? Well, one, the traditional diagnosis, treatment, and referral of individual patients. But increasingly, our task is also to motivate and facilitate healthy patient behaviors. And of course, this is not just a task of doctors, it's a task of the team. It's a task of enabling technology. There are lots of bots and algorithms, text messages, and other means to motivate patient behavior. To manage population health outcomes. We are no longer just concerned with Mrs. Williams' hemoglobin A1C. We start now by saying, what is the hemoglobin A1C of all of the patients in our practice? How can we stratify their risk? How can we affect them as a population? To help lead and manage treatment teams, as you've heard before. Modern medicine is a team sport, but I reinforce the word help lead, which is different from lead. Primary care doctors, just like primary care nurse practitioners or physician's assistants or LVNs, are kind of like running backs on a football team. Sometimes they have the ball, sometimes they're blocking for other people who have the ball. Sometimes they are diverting the defense so that someone who actually has the ball can get through. And of course, continuous learning and quality improvement. You have your job to do, and you also have to improve your job. And I want to point out that all of these things require organization. That's an important concept because lots of the people who went into medicine in particular did so in part, as one dean told me when I was in medical school, so that nobody could tell them what to do. All of these tasks require organization in which physicians, nurses, and other health professionals have to participate. And an important area of research is actually in organizational behavior. How should this work be organized, stratified? How is it scheduled throughout the day? What's the optimal role of different people in an organization to make these tasks come to fruition? I think it's important for us to think about what COVID has taught us. And as I said, it would be folly for us to talk about a research agenda for primary care or a role for primary care based on conditions 20 years ago. I think it'd be folly for us to think about it based on condition 20 months ago. So our task is not, okay, phew, the epidemic seems to be waning, the pandemic is rolling back. Let's go back to what we were doing before this all started. What has COVID taught us? One, it's taught us that racial, ethnic, economic disparities in our society are pervasive and deadly. For anyone who did not know that before, they surely know it now. Two, much of in-person care is wasteful and unnecessary. Healthcare and education in particular have had to pivot on a dime to new methods and new approaches which were technically possible, but were blocked by reasons of culture and payment. And now we need to think about what aspects of that pivot should remain in place. Third, volume-based payment is fragile but persistent. And so any kind of enterprise, whether it's a hospital or a primary care practice, which got paid when people showed up, is in trouble when people don't show up. And yet, we've already seen that people are desperate to go back to that payment method, which has frankly served healthcare providers fairly well in many instances up to now. So the task of trying to figure out how you do some payment method that does not rely on people showing up in person, that is to say, managing their outcomes rather than their visits, is increasingly important, and I think will be increasingly accepted even by people who weren't really crazy about that idea 20 months ago. Successful primary care practices of the future, I believe, like all practices, including specialty practice, will have to have 4 channels. By channel, I mean, as the Cambridge Dictionary would describe it, a way of communicating with people or getting something done. What are the 4 channels that we have now? What are the channels, the ways of getting something done that primary care has historically used? Well, the first one, and by far the dominant one, was in person, a little bit by telephone, some increasingly in recent years by asynchronous means, emails, text, chatbots, etc., and a little bit by video. I think we will dramatically decrease in person and dramatically increase asynchronous. And I'm pretty confident that 5 years from now, asynchronous, video, telephone, and in-person in that order will be the way that most people access the healthcare system for first contact for many routine things. That's not to say that bricks and mortar medicine will ever go away, but it is to say that the pressing research environment in which I think primary care and much of healthcare will be delivered is a hybrid one that has to have completely new rethinking of how work is organized, how quality is assessed, and how performance is judged. Let me just say here, as an aside, I'm a big believer in value-based care. I'm a big believer in value-based care for primary care. Part of the reason I think it's been difficult to move forward on this task is that primary care faces some particular challenges in applying value-based payment to its work. First, because patient and social factors are often beyond providers' control. The capacity of your patient to successfully manage losing 30 pounds and bringing their BMI into compliance and therefore reducing their risk for diabetes and osteoarthritis is often dependent on things that are way beyond the control of any individual practitioner or even health system. Second, it's difficult so far for us to figure out how to adjust for socioeconomic status, which is often behind these out of providers' control factors. Third, there's limited robust science on optimal treatment of patients with multiple conditions. We may know how to treat heart failure. We may know how to treat kidney failure. We have a hard time knowing how to treat someone who has heart failure and kidney failure, metabolic syndrome, osteoarthritis, and multiple conditions which are often faced by primary care providers. Fourth, the primitive state of risk adjustment, which would insulate someone from the fate of being paid less money to take care of sicker patients. Fifth, as Jen said, there's often a long timeline for outcomes. And so it's wonderful to treat someone and reduce their high blood pressure, but the economic payoff for reducing their high blood pressure may be decades from now rather than weeks from now. And lastly, there's the problem of patient and public sentiment. Are primary care providers coaches and coordinators, which is how we'd like to see it, or gatekeepers and demand reducers, which is how other people in the healthcare system like to see it? Threading that needle, because the optimal role for primary care frankly contains some of both, I think is an important task to get right. So what's the research agenda for the new primary care? One, self-service. None of us does anything in the service industry the way we did it 15 years ago. We don't bank, we don't shop, we don't do research the way we did it 15 years ago, except for the most part healthcare. And so there's a big area of healthcare in which patients can and should be given enabling technology and training and opportunity to use it to replace professional activity with personal self-care activity. Second, website management. What does it mean to both be satisfactory to patients who call in and want an antibiotic for a routine URI, but also maintain good antibiotic stewardship? How do we replace the things we were taught, however imperfectly, about how to relate to a patient when he or she is facing you in person with a new situation in which you're dealing with them by email or phone or video? Third, how really do we go about changing patients' behavior? It's all very well and good to write a note saying patient was urged to lose 30 pounds. But actually getting that patient to lose 30 pounds involves some science and a lot better outcomes than we've had so far by shaking our fingers at them and recording notes. Fourth, we were just getting to the point where we're trying to integrate behavioral health with primary care in a bricks and mortar world. Now, in the last year and a half, behavioral health in virtual care has exploded. We have a whole new task to try to figure out how to integrate behavioral health into primary care in a hybrid world for both. Fifth, clinical guidance for complex patients. As I said before, we've got pretty good algorithms for single disease states, but for multiple overlapping, sometimes conflicting disease states, we need much better science to guide providers and their teams in care. Sixth, how do we organize providers' work? How do we pay them? How do we schedule them? What is the correct or optimal interaction of patient advisors, nurse educators, doctors, administrators, front office staff, back office staff to make an organization have optimal impact on patients' experience, on the efficiency and convenience for patients, and getting good health outcomes? Seven, how do we use non-creepy ways? Non-creepy is a technical term here, to use so-called health data on social determinants, the impact of people's housing circumstances, their work and transportation circumstances, their access to good, safe, nutritious food and others, but also their social media postings, their search behavior, their shopping inclination, data which, by the way, many tech companies have far deeper understanding of patients, their social milieu, their concerns, their fears, their predilections and tendencies, much better understanding of them than we do. I have no idea how to use that data in a non-creepy, again, technical term, way, but we ought to have to figure out how we use better sources of data than asking people, how healthy do you feel? And lastly, applying an equity lens to everything we do. This includes, by the way, telemedicine, about which I am absolutely clear that it is part of the answer to solving the disparities and inequities in healthcare, but that without a conscious effort to mitigate its potential downside, it can lead to increasing those discrepancies, disparities, and inequities with unintended consequences. And so that's my contribution. I'll look forward to our conversation, and thanks. Back to you, Arlene.
Thanks so much, Dr. DeVoe and Dr. Smith, for those outstanding presentations. And it occurred to me while I was listening to both of you that, Jen, you really laid out, aspiration, what primary care should be, and some high level 20,000 foot, like goals for getting there. And Mark, you brought us down to reality that there's we can do it, that it's critical to do it, but that there's huge challenges again. And I think we need to be focused and targeted and do it right. And so I think I'm going to just start with, first asking Jen, and then Mark, you could follow. Jen, how do you see research, the role of research in the NASEM's report's agenda and the priorities in terms of research to move the agenda forward? Really, given that we've been working to advance primary care for many decades and we seem to be losing ground rather than gaining it. And then Mark, I would like you to follow up with, given, you're really right on target research agenda, how do we actually prioritize and implement it to get actually the highest value out of our research?
Yeah, really, really great questions. Thanks, Arlene. I will say that there are areas that research is desperately needed, as you mentioned, and one of them is related to our interprofessional teams. I think it's a really exciting time to have teams in primary care to understand, as Mark laid out so great with the football analogy, who has the ball, what each of our roles might be, and what particular circumstance we find ourselves in. So I do look forward to research helping us to determine who needs to be on the team, which team member can be providing excellent care to the patient at any particular time. The skill sets of the teams are very complementary. And so I do look forward to that being an area where a lot of research is needed. I think I mentioned that one of my patients, Solomon in particular, did teach me that it's possible to deliver the old-fashioned romantic care, but in a futuristic way. So I think ways to achieve not only the aspirational goals and maintain the relationship-centered care and knowing the sound evidence for continuity of care and relationship-based care, and then bringing that care into the 21st century, as Mark described, with asynchronous care and digital tools, video, phone being predominant ways of delivering care. And so how do we do that well? How do we optimize all these different tools in our toolbox while not completely abandoning some of the bedrock aspects and the secret ingredients that we found to be so important in primary care, focused on relationships. So there's a lot of research in moving to where Mark described, as well as maintaining some of the old-fashioned, more romantic notions of primary care and what's really been some of the secret ingredients that have made primary care successful for some people. And then I think, as we mentioned in the report, how do we get that to all people in an equitable way? So lots of really big challenges there as well.
So I agree with that. Let me give you a contrast between two different sets of ethoses. An academic ethos and an entrepreneurial ethos. I think part of the challenge for research here is that the research enterprise and most of the researchers exist in one world, and most of the most dynamic and innovative changes in primary care are happening in a different world with a different timeline, a different level of evidence necessary for decision making, and a different physical space. So there are a bunch of organizations out there that are delivering primary care really in a very new way, some of them are very technically enabled, really kind of Buck Rogers stuff. And instead of hiring more and more people to be on these teams, they're actually trying to replace people with technology, often largely successfully. On the other hand, there are other new primary care organizations that are taking care specifically of people with multiple chronic diseases, people who are homebound, people who have difficulty mobilizing to get into an office. Those are not happening in academic centers, but the research is happening in academic centers by academic people who had very little contact with these new organizations. And so part of the problem, I think, is bringing together the academic enterprise that's doing research with the place where the innovation is actually going on. And part of that means I'm also a recovering foundation executive. Foundations and governments tend to fund a study that says, here's what you're going to do. You're not going to change it for the next 24 months because we want to study what happens. At the end of 24 months, we'll spend a year writing the paper. The paper will take 6 months to be reviewed. Then it'll be put in the queue. And 3 years later, we know what happened with a project that didn't change from its initial conception until 2 years later when it was finished. That's not the way entrepreneurs operate. That's not the way innovation operates. It's iterative. People are testing and learning and changing stuff all the time, and often have to make decisions based on a much lower level of certainty, kind of rigor of evidence than is traditional in academic research that's funded by people like ARM. And so I think part of the problem here is that the innovation is going on much faster in the real world than our traditional academic research enterprise can keep up with. And we've got to figure out a way to merge those two worlds a little better if we're going to be productive in this effort.
No, thank you, Mark. And I think, ARC is really looking at how we can do research differently, because I think you're right that that's a key solution. Can we use rapid cycle evaluation? Can we use adaptive designs? How could we learn along the way? And also, how can we not fund research where it's going to be a negative trial? So why keep going? Why not adapt midway? So I think that's a challenge to the research community, and developing these methods in a way that are scalable and rigorous and could be widely used to really produce the evidence we need. The other thing I was really happy to hear you bring up is the challenge of managing people with multiple chronic conditions, because that's the bulk of the population at this point. We know it's a syndemic because all the risk factors for one chronic disease are the risk factors for all the other chronic disease. And we don't do a good job of taking care of them. And they do have incredible difficulty navigating the system and getting fragmented care that could actually produce harms. But on the other side of it is like people don't have that vision of primary care. And I actually do believe that primary care is the answer to taking care of this aging, complex, and increasingly sick population. But there's been underinvestment in primary care. There's been de-skilling of primary care. So what are the solutions to enable primary care to actually tackle one of the biggest population health needs we have currently?
Well, I'll lead off on that. Well, first of all, I think part of the answer to that is the answer to the previous question. We need lots more data from lots more patients in real time. And here's where I think having a different research infrastructure and using some of the newer techniques of machine learning can come to the rescue. So there are people at Stanford and elsewhere who are able to give us answers to clinical questions that could not be answered by traditional kind of standalone research projects. And to the extent that you have data on thousands or hundreds of thousands of patients with overlapping conditions and can see what the outcomes are with different treatments in the real world, you can get much quicker answers to some of these questions about what do you do with people who have this and that. And if they had this, you would zig, but if they had that, you would zag, but they have this and that, so what do you do? So that's one of the places where I think having much wider collection of data in real time that's now much more available clinically, being able to apply machine learning to that data is one of the bright spots, I think, of where we can advance this clinical science by using new research techniques.
Yeah, I was thinking along the lines of really more robust surveillance systems. So along the same lines that you're talking about, Mark, that, is there a way that we can just have, millions, if not billions of data elements in a way that's real time so that we can surveil what's going on. And, these people over here are trying this experiment and, we're seeing a signal amidst the noise. And so then let's, expand and implement whatever intervention they're doing over here in this one place to 10 more places and see if we're still seeing the signal get 10 times stronger and then do it at 100 and 1,000. understanding that each patient and family and community are somewhat different. And so how do you more precisely tailor what those people need based on many of these risk factors, whether it be their socioeconomic status, their family history, their preference, whatever the case may be, as well as all the medical data that we currently have in electronic health records. So in a non-creepy way, as you said, Mark, how do we put all this data together to understand what a patient needs, and then what best structure or system of primary care is gonna meet those needs?
Yeah. And both of you, mentioned equity, and actually, multiple chronic conditions is really an equity issue, because people who have more, social needs, social risks, develop more conditions, develop them earlier in life, and then have the double whammy of having impaired access to care, and then maybe suboptimal quality when they do get care. And, clearly primary care, if it's done right, could be a huge solution to providing, accessible, equitable, integrated care, which is what the, report said. But maybe I'll start with Mark here in terms of how could we, you mentioned applying the equity lens to all the research we do. So could you just elaborate a little bit on that, and the kind of evidence we need, and the changes we need in the system to really make it more equitable?
Yeah, well, first of all, we need lots more data. So we simply have to expand the degree to which we have data on ethnicity, on principal language, on gender, where appropriate, on gender preference and sexual preference and gender identity. But we also have to look at what our quality measures are. And my own view is that this really doesn't start with trying to create new quality measures. It starts with trying to look at the quality measures that we already collect, that we already find valuable, and analyze them by the axes that we know have inequities in them. So let's look at discharge planning, or by readmission rates by race. Let's look at net promoter scores or HiCap scores by gender. Let's look at diabetic control or hypertension by principal language. And I think we'll find lots of places where we have opportunities to improve if we take whatever quality measures we think are important in our line of work, in our institution, in our service line, in our department, and look at them by these axes. I think we'll find places to go to work.
And I think, just building on the point that I made before, oftentimes we see disparities in those outcomes, I guess I want to say kind of on the back end, where what we need to do is we need to understand what the predictors are, most importantly, so that we can understand those on the front end. And we can say, we know that a patient of this race, or with this gender identity, or with this language is already at risk for having poor outcomes, or having inadequate or inequitable care. So then you've got to really move that front and center, and understand maybe you need to pay differently based on the patient population. Maybe you need different people on the team based on that population. Maybe you need different resources in the community and or in the primary care setting, or in any other setting, as opposed to one size fits all.
One other point, Arlene, that's really important. If you're doing equity work, as Don Berg would say, averages are your enemy. Averages are your enemy. Arlene, if you and Bill Gates walk into a bar, your average net worth is $46 billion.
Oh, wouldn't that be nice?
Now, I don't know what your net worth is, but I suspect it ain't nowhere near $92 billion. So you cannot be satisfied with average blood pressure control or average hemoglobin A1Cs. You got to break that down to see where the discrepancies exist.
Yeah, and I would add, then we need to learn how to close that gap and what works. And then I think some of the things we were talking about earlier is learning what strategies actually, first we need to measure the problem, but then as we're intervening to address it, what actually works and how do we make it work? So yeah, I think there's, huge opportunities there, but I think that also, primary care is really foundational, and giving everybody access to effective primary care and making sure that it's effective and equitable is really a first step to addressing some of the, pervasive inequities we saw during COVID. Mark, do you want to add something?
Yeah, let me make this point. Equitable doesn't necessarily mean the same.
Mhm.
And I think one of the problems that primary care romantics like myself still struggle with is the notion that there is some idealized system of primary care which is right for everybody. Not everybody needs or wants the same intensity or longitudinal relationship with individuals. Not everybody has the same proclivity for or affinity for technology. So I've been to public health school and I've been to business school. Public health school taught me to be a lumper, like what's best for most people. And business school taught me to be a splitter. Some people like Coke, some people like Pepsi, some people like cherry Coke, some people like diet cherry Coke. And so I think our notion of primary care, which is a little bit still stuck in a romantic, here's what it looks like. I think it looks very different for a 72-year-old with multiple chronic conditions and a 32-year-old who's got nothing, right? That person doesn't need necessarily the same longitudinal relationship with an individual who knows his or her family background. And so again, I think we've got to be willing to have different interfaces, different mixes of technology that are appropriate for and equitable to people, but that doesn't necessarily mean kind of a vanilla, here's the way we practice in this practice.
Well, and I would add that everybody needs different care on a different day. So doesn't matter what age you are or what chronic conditions you have or don't have. One day, calling up and speaking to a clinical pharmacist about some side effects from a new medication might be exactly what you need. The next day, it might be texting with your community health worker who you've built a relationship with about where the best places are in the community to improve your health, get the access to weight loss opportunities. And then it might be the next day that you really do need to see that doctor because you've got a very rare condition or rash or something else that they need to see you in person. Although even with rashes, more pictures are being sent across the internet every day. But there's certainly, I think for each individual, there's going to be, and that's where the teams come in and the 4 channels, as you said, Mark. I think there's 4 different days, 4 different channels for the same person.
Right.
Yeah, and it's interesting, Mark, what you're saying about, sort of the heterogeneity of the population, the heterogeneity of needs, of being able to really target people and provide them what they need. I'm thinking about a commentary I wrote quite a few years ago, talking about precision care. Like there's this whole, image about precision medicine. We're going to, know the right genomic treatment for everybody, but we haven't invested on how do we deliver the right care for the right person at the right time and the way that they need it. And can research help support like learning how to do that moving forward?
I remember many years ago, before some of you were born, the beginning of what we now call retail clinics, minute clinic, these kind of places located in big box stores. I remember the American Academy of Pediatrics putting out a statement saying, we believe in the medical home. This is not the medical home, so we urge our patients not to use them. And I said, well, my goodness, you're a board certified pediatrician. You've got an hourly worker mother who's got a screaming febrile child at 2 o'clock on a Saturday afternoon. What would you have her do? Would you have her wait till Monday when you're there? Would you have her go to the ER and perhaps spend a month's salary to have somebody see her? So I worry sometimes that we're caught in our own conception of what care should be, often frankly linked to our own economic interest or our own semi-romantic notion about what it should be. And I just hope that we can continue to uncover what works for patients. Because frankly, what works for patients is not always what works best for us in our current configuration or our current reimbursement system. And so that's why I think the work that PCORI has done and truly taking a patient perspective is important. It is worth noting that the so-called medical home turns out to be a name that patients hate. And so if the patient-centered medical home wasn't even named in patient-centered way, one has to worry whether its conception was truly patient-centered or if it was kind of provider romantic-centered in terms of what it was supposed to be.
Oh, so this is a great discussion, Jen. I'd love to hear your comments, but I see we're kind of just about out of time. Do you want to quickly jump in with a quick few second comment?
I think my few second comment was just to highlight your point about flexible reimbursement. I think that there's a lot of innovation that can happen when we pay comprehensively in a flexible way so that we can meet patients' needs where they are.
Great. Well, thanks so much. I can't thank both of you really enough for this really thoughtful and provoking discussion.